Hello, everyone. Welcome to Heart Healthy Arizona, presented by the All of Us Research Program at the University of Arizona in Banner Health. My name is Sadiq, and I am one of the program managers with All of Us. Today, we're excited to bring you four amazing panelists to explore how our habits and lifestyle may impact heart health. Panelists, thank you so much for being here with us tonight and sharing your time with us. We're excited to learn more about heart health and how it affects our lives. Joining us on our panel is Dr. Tomas Nuno, Dr. Michael Grandner, Dr. Elizabeth Juneman, and Miss Melissa Lopez Pentecost. We're going to get kicked off by handing it over to Dr. Tomas Nuno. So he is one of our co-investigators for the All of Us Research Program with University of Arizona and Banner Health. And he's also an assistant research professor in the University of Arizona Mel and Enid Zuckerman College of Public Health, Department of Epidemiology and Biostatistics. Dr. Nuno's research primarily addresses issues of chronic diseases, prevention, and including disparities among underserved populations. Primarily, he focuses on cardiovascular diseases and diabetes in the Hispanic populations in the US. I'll go ahead and hand it off to you, Dr. Nuno.
Thank you very much, Sadiq. Hello, everybody. It's my pleasure to be here today with you, and I'm very happy to give you this presentation on heart health disparities in the United States. I'll also see you at the end when I talk a little bit more about the All of Us program. So to begin with, health disparities in the United States, they exist by ethnicity, race, geography, and socioeconomic status. But go back a second. What do we mean when we say health disparities? There's lots of definitions, but one key one is health disparities are preventable differences in the burden of disease or in opportunities to achieve optimal health experienced by different groups. Next slide, please. Oh, there we go, yeah. So a person's race or ethnicity, it shouldn't put them at risk of having heart disease or stroke. But unfortunately, it is one factor that affects a person's likeliness of suffering a heart attack or stroke and chances of survival if they do. So cardiovascular disease overall, including heart disease and stroke, it remains the #1 killer of Americans. And it extracts a disproportionate toll on many racial and ethnic groups that have higher rates of CVD and its risk factors. Next slide, please. So we can think of it in a few different ways: at the patient level, the provider level, and the systems level, factors that affect the heart health disparities. So at the patient level, individual factors, so including our diet and exercise, things that we hear lots about, always improving our diet and exercise, potentially genetic factors, they may contribute to the heart health disparities. At the provider level, factors can include unintentional biases when you go to your provider, your doctor, or access any services, and the varying sensitivities to the needs and differences of patients from various backgrounds. So those issues of when we say patients not feeling comfortable when they visit a provider, that they don't feel they have something in common with, that could be factors that affect that. And at the health systems level, the specific factors can include access to care, insurance coverage, cultural competency, and the kinds of infrastructure required to address the needs of diverse patients. Next slide, please. So some examples of heart health disparities among different groups. So below, there are some examples among different racial and ethnic groups. So we have the disease impact by 3 different groups. First, the first group we're looking at Black and African American. So the font's a little small, but hopefully you can read that. But I'll go through it for the most part. And you can see that among Black and African American, these are where heart health disparities are really stark. They really stand out. The issues faced there, historical issues, definitely show in these numbers. And their numbers, such as Black or African Americans, 30% more likely to die from heart disease, twice as likely to have a stroke, higher rate of myocardial infarction, higher rate of heart failure, higher functional impairment from acute coronary syndrome, and higher death rate from acute coronary syndrome. So these disease impact, these outcomes are very stark and just stand out and need to be addressed. And we'll talk about how programs like All of Us and other research is working towards that. Among another group, Asian American and Pacific Islanders. So coronary heart disease, it occurs earlier in life and in a higher percentage in the population of Asian Indians and in other ethnic groups. So there are some disparities there that are visible among Asian Pacific and Pacific Islanders. So this last column is non-white Hispanic. So among non-white Hispanic, they show lower rates. They do show lower rates of overall cardiovascular disease, but when we look more by subgroups, Puerto Rican Americans have the highest hypertension-related death rates of all Hispanic subgroups. And the rate of heart failure for Hispanics is lower than for African Americans, but higher than for non-Hispanic whites. Next slide, please. And actually, and since this is the area of focus of my research, I have a little bit more information to provide among heart health disparities among Hispanics. And it's a little nuanced. There's like a lot of things going on. Some things are kind of contrasting, and it makes you think there's some things happening that are kind of hard to reconcile. But among those are, so despite a distressingly worse cardiovascular risk profile, overall Hispanics experience lower all-cause and cardiovascular specific mortality compared to non-Hispanic whites. So when we talk about a distressingly worse risk cardiovascular risk profile, we're talking about things like higher rates of overweight and obesity, high blood pressure, higher rates of high blood pressure or hypertension, higher prevalence of type 2 diabetes, higher levels of total cholesterol and LDL cholesterol, higher triglycerides. And then there's also like issues such as more psychosocial stress levels, so higher psychosocial stress levels. So there's factors of clinical and behavioral factors. So despite these risk profiles, overall the numbers, you say, well, they're not that bad. There's no disparities there. So this is what this phenomenon is in the literature. It's referred to as a Hispanic mortality paradox, and it's been researched, and there's different studies going on that are looking at that, including all of us, which is something in the future when I talk about more about the numbers and what all of us intends to do, how this can address this seemingly contradictory finding. But this observation, with the significant growth in the Latinx population, so fuels a need for greater understanding of cardiovascular disease, specifically among Latinx populations, to one, appropriately model risk. So because when we think of the Latinx or Hispanic population, there's definitely quite a bit of heterogeneity in the group. So we have groups that come from different areas, so different, countries, Mexico, Puerto Rico, Central America, South America. We have different racial, so we have Hispanic, white, Hispanic, Black. So you have lots of things going on there, and cultural factors, cultural behaviors of maybe Central America, Mexico, close-knit to the US, and a cultural relation of levels of foreign-born versus domestic-born, and length of time in the US, a culturation to, say, US type of diet. So appropriately modeling these risk factors of all these different things going on is going to be important for the future. Overall, a younger population, as this population ages, we'll be seeing potentially issues going on with, and seeing if this Hispanic mortality paradox holds. So I've identified resilience. So there's also, when you think of cultural factors, resilience factors, these are things that need to be studied among this group, with all the different things of cultural and in society going on. And improving targeting interventions. So the interventions that look at efforts with broader economic and health implications for the nation as a whole. Next slide, please. So overall, addressing heart health disparities. So racial and ethnic minority groups more frequently lack health insurance and have limited access to quality health care. So it's essential that healthcare providers understand the nuances in disease presentation, risk factors, and treatment in different racial and ethnic groups and communities. Because decreasing health disparities, it must be a significant goal at the patient level, the provider level, and the health system level. So at all those levels that I mentioned, where these health disparities can be addressed. Next slide, please. And this is my last slide for this health disparities presentation. This is what I like to, when I work at, my overall focus is prevention. So I call it the social ecological model framework for prevention. So for me, it all starts at the individual level. So the knowledge, attitude, skills starts at the person. You're the person. It's your diet, lifestyle, what you're doing. But you're also, it's not just you in a vacuum. You're part of an inner person. You're part of a family, friends, social network. You're part of an organization, social institutions, part of a community, and then also we mentioned the provider and systems levels. And then there's the overall public policy, the national, state, local laws and regulations. So I like to think of this as it starts with the person. And of course, we all admire that person that can overcome all these great odds that they're faced. They're able to pull them up by their bootstraps and get healthy or stay healthy or lose all this weight or avoid disease. But it shouldn't be that difficult. It should be something that our policy should be to provide resources at all these levels. And I think I have a minute and a half to give a little bit of a personal story on my own note on this, starting at the individual level. Over 4 or 5 years ago, I changed my diet. I dropped from about 250 pounds to the lowest I got is 176. So in about a 3-year span, I did that. Because of COVID, I put about a 10 back on. So I had the COVID issues going on. But at the individual level, okay, I took it. I said I need to change, but it wasn't just that. I had a family, my wife, support to improve my diet, to have the resources I have because of my job position. I have health insurance, doctors, and access to resources. So I say that as a try to give a personal example of how we can think of all this and make it so that people can be as healthy as possible, and by addressing at all these levels, that it's not just at the individual level or at the big level. It's all this working together. And that's my presentation for this part. Thank you.
Thank you, Dr. Nuno. We appreciate it. Next, we're going to hand it off to Dr. Michael Grandner. He's a licensed clinical psychologist and director of the Sleep and Health Research Program at U Arizona, and the director of the Behavioral Sleep Medicine Clinic at the Banner University Medical Center in Tucson. His work focuses on translational sleep research and behavioral sleep medicine, including studies of sleep as a domain of health behavior and the development and implementation of behavioral interventions for insufficient sleep and sleep disorders. I'll go ahead and hand it off to you, Dr. Grandner.
All right, thank you. And I guess first I want to say that sleep also exists in a socio-ecological context. I mean, we have ourself that sleeps on our own wherever it is that we sleep, but our sleep is partially dictated by our own choices, our genetics, our beliefs, our demographics, our age. But we also exist in a social context. Things like, I mean, how many people can say not one day in the last week was their sleep at least partially influenced by their family or work or friends or their neighborhood noise or anything like that? And then even still, the social level exists in a societal context as well, where things like 24/7 society, globalization, racism and discrimination, public policy, the environment, technology, you know, the fact that we have all these things in our rooms every night. It's not a coincidence that everyone's behaviors change, it's that society changed. And so sleep exists in this context as well. But sleep is not a luxury. Sleep is a non-negotiable biological requirement. We sleep for the same reason we eat and breathe air and drink water. It's because it's just part of our biology. It's not an interesting romantic answer. It's just that's what we're built to do. It does lots of things for us, and we're still learning that all the time. But why do we sleep? We sleep because we have to. And if you go too long without it, your body's going to take it whether you like it or not. It's like you can only hold your breath for so long. Your body's going to take that breath whether you like it or not. Yet we don't say things like, you know, drinking clear, unpolluted water, you know what, that's for people with too much free time on their hands. We don't say things like, you know, when I retire, I'm going to breathe clean air. You know, until then, like, I'll make do with all this pollution. We don't say that because that would be dumb. But we do say that about sleep because our society has an interesting and complicated relationship with sleep. We see sleep as unproductive time, and we're so busy and we have so much to do, we never feel like we have enough time. So we see sleep as a cost of time, when really it's an investment. Why is it so important? Sleep helps your body repair itself. It does many things. One of the things it does, it helps your body repair. Getting enough good sleep also helps you function normally during the day. Sleep is not, you know, not something you should be living paycheck to paycheck with your sleep. It shouldn't be how many hours do I have left at the end of the day to spend on this. It should be like your commute to the next day. When do I need to leave the house to get there on time? When do I need to go to sleep so that I can wake up functional and effective and good for tomorrow and invest in my own health? Getting good sleep isn't just important for energy. It's also critical for heart health too. There's decades now, actually more than 50 years ago, the first discovery that people who didn't get enough sleep or slept for like 9, 10, 11 hours, who got excessive sleep, people who weren't getting the recommended 7, 8 hours didn't live as long. And this has been something that's been repeated over and over and over again for over 50 years. Now we're trying to figure out why. One of the reasons is that sleep plays important roles in your heart. Your heart is really important in regeneration and serves so many areas of your body, and the heart is very sleep dependent. The problem is 1 in 3 American adults report the amount of sleep that they get is in a high risk range for heart health. 6 hours or less is about a third of the US population, and that's associated with increased weight gain, obesity, hypertension, diabetes, because it doesn't allow your body to do the work it needs to do to repair and be ready for the next day. If you look at all the guidelines, if you look at the evidence, most adults probably need at least 7 hours of sleep. 7, 8 hours is sort of the target. Next slide. Over time, sleep problems can hurt your heart health. And this has been tracked again for decades, that when you look at people who don't have heart problems, but they have sleep problems, versus people who don't have heart problems and don't have sleep problems, the ones with the sleep problems develop the heart problems faster. So if people have healthy hearts, but one group doesn't sleep well, the group that doesn't sleep well is much more likely to develop heart problems. It can lead to serious health problems and make other health problems worse. Whether it's heart disease, diabetes, depression, substance use, pain, inflammation, brain health, all these things are interconnected. Adults who sleep less than 7 hours a night are more likely to say they have health problems. They're more likely to have had a heart attack, have asthma, depression, strokes. I mean, pretty much any outcome that's health related, that's tied to some biological process, is probably at least connected to sleep in some way. And some of these problems raise the risk for heart disease, heart attack, and stroke. So not only does it impact heart and blood vessels directly, but also indirectly. Things like stress, things like diet, things like lack of energy and not being able to move, things like food cravings, and all of these sorts of things are impacted by sleep. Next slide. So here's my 2 cents for what people can do. First of all, stick to a regular sleep schedule as much as you can. The body doesn't know what a weekend is. The more regularity you can build into your system, the more your body can use time and your routine as an ally toward better sleep. If you train yourself over and over again how to sleep, your body's going to recognize that pattern and help you. You should get enough natural light, especially earlier in the day. People don't think about light for sleep. They think they want to avoid light at night. But what you want to do is get bright light in the morning. It helps set a strong circadian signal to start your day. A morning or lunchtime walk is perfect because you're combining it with physical activity. And there's actually data that shows that adding even a little bit of activity to that light exposure dramatically improves its biological efficiency. Getting enough physical activity helps promote sleep. Not only does it make you tired, but it helps improve many aspects of health and oxidative stress that help sleep do its job properly. But try not to exercise strongly within a couple hours of bedtime. If that's your only time to exercise, do it. I'm not going to say don't. If you do and it keeps you up, maybe move it. But try and especially get it in the morning. That seems to be the most effective. Avoid artificial light right before bed. So you want light in the morning, but you don't want to send a daytime signal when your body's looking to find out when it's nighttime. So you might want to put down screens or at least start dimming lights within an hour or so of bedtime. Don't eat or drink too much before bedtime. Not only is that more likely to put on weight, there's a whole rabbit hole of literature there in terms of how and the clocks and how your body manages energy metabolism, but it's more likely to disturb your sleep. If you're drinking a lot of water, you're more likely to get up more during the night. If you're eating more food at night, you're more likely to have metabolically active processes that could disturb sleep or reflux even. And also keep your bedroom cool, dark, and quiet and comfortable, not rocket science. But also, if you do all this stuff and you're still having a lot of sleep problems, maybe you have a sleep disorder and you may not even know it. And so this isn't enough to fix a sleep disorder. This is all stuff that people should do. But if you've got a sleep disorder, talk to your healthcare professional. There are treatments, and it's not just sleeping pills either. We've got lots of solutions for sleep problems. And a lot of people are surprised how treatable these are. So thanks a lot.
Thank you, Dr. Grandner. Next, we're going to be handing it off to Dr. Elizabeth Juneman. She is an associate professor in the Division of Cardiology in the Department of Medicine at the University of Arizona College of Medicine, Tucson, where she currently serves as the medical director of advanced heart failure and transplantation. She is a member of the Sarver Heart Center, and her research focuses on mechanical and cellular remodeling in heart failures, cardiac physiology in the failing heart, and women's cardiovascular disease. I'll go ahead and hand it off to you, Dr. Juneman.
Thank you, Sadiq. Thank you for inviting me to participate in this webinar. I've got a very large topic to try and cover for women in cardiovascular disease. It is an area that affects, 50% of the population. And I thought I'd start off with just giving some recent statistics. So as a woman and as a cardiologist, recognizing that heart disease is the #1 killer in the United States is important because it is an equal offender for both men and women. So this curve looks at the mortality in the United States, or deaths attributable to heart disease since the turn of the century, 1900, up until 2017. And I can tell you that in the mid-20th century, we were able to have a lot of advancements in treating cardiovascular disease. We've recognized that smoking was bad. We recognized that we have really good medications to control blood pressure, that medications for high cholesterol do things and make people live longer. But what's interesting about the tail end of this curve is that at the beginning of the 2019 to 2020, we started seeing an uptick. This uptick really has nothing to do with COVID-related deaths, but had an indication that overall, we as a society are seeing an uptick in the amount of deaths from cardiovascular disease. If you look at the specific women data, what you recognize is that women are no different than men. Heart disease is the #1 killer of women in the United States, more than cancer and breast cancer and traumatic deaths. So look around you and your family, your friends, your neighbors, and your loved ones, and recognize that the chances of a woman dying of cardiovascular disease is the highest of any other death. Next slide. So when I present this lecture, and I do give this lecture to medical students, I start off by saying that it is very important to recognize that women have worse outcomes across the board for cardiovascular disease. And let's take each one of these one at a time. As compared with men, women with heart disease tend to be older. That's not necessarily secondary to hormones alone, but we do know that women tend to be anywhere from 5 to 10 years older when they present with heart disease. In general, women tend to have a heavier weight as compared to their male counterparts. We are more likely to have high blood pressure, diabetes, and kidney disease. We are more likely to be not treated aggressively for hypertension, diabetes, and kidney disease. And if we present to the hospital, we're less likely to be admitted to the hospital as compared to men. We're less likely to undergo stress testing. We're more likely to have complications after invasive procedures like a cardiac catheterization or angiogram. And sadly, we're more likely to die after a heart attack, more likely to have heart failure, less likely to be referred to cardiac rehabilitation, and less likely to get hospital follow-up. Now, as very well outlined by Dr. Nuno earlier, is that there's multiple reasons why women have worse outcomes. It is partially the recognition that women tend to not think that heart disease is, in fact, the #1 killer. Number two, I think at least in years prior, there had been a bias toward male-specific symptoms. Luckily, all of our students and doctors that are in training now and nurses recognize that women can have and do have unique symptoms for heart disease. And we really need to focus on diseases, treatments, specific research that focus on cardiovascular disease in women. Next slide. So if we look at the data on women, In general, what we see is that there's very little randomized studies of prevention of heart disease in women. Some of our biggest studies were actually done in large nursing cohort studies for which they followed women over time. But in general, if you look at all of the clinical trials that are published on many of the medications and therapies that we use for heart disease, women actually comprise less than 25% of the enrollees in those clinical trials. If you break down that percentage of women, even less data is on women in racial and ethnic minorities. So looking at clinical trials for which that we can target specific racial and ethnic minorities and look at targeting treatments is very important as we look at heart disease treatment in the future. Currently, there are no gender-specific guidelines for treatment. But I will tell you that here at the University of Arizona and at a lot of other academic centers, we are actively, as a cardiology community, pursuing treatments and trials that enroll women and look at the underlying causes for women. Next slide. So I think when we talk about prevention, I think both men and women should consider cardiovascular disease as being a preventable disease. And we can talk a little bit more about that, specifically as Ms. Lopez presents nutrition. There are likely sex-specific differences. We have seen that in both animal models and in human models. There are probably sex-specific strategies. We need more research in order to try and determine what best treatment works in women and what best treatment works in men. Already in some of the new clinical trials that came out recently and are going to come out at the large meetings, we are seeing that there are specific drugs that may trend a better result in women as compared to men. Next slide. I can't talk about women and cardiovascular disease without mentioning pregnancy. As a cardiologist, I was shocked to recognize of all developed countries in the world, the United States ranks the last as far as maternal mortality in pregnant women. And that was shocking to me because given our healthcare system, I really was disheartened to recognize that we are last. When we look at all pregnancy-related deaths, over 50% are related to cardiovascular. Of those, a large proportion is related to heart failure after pregnancy. And a majority of those deaths are after pregnancy. So if you think about it, that is a time for which that a woman is most likely tired and sleep deprived, dealing with a newborn, and often putting her newborn and her family before her overall care. And this is what we at the University of Arizona are trying to focus on, is cardiovascular care for pregnant women after they give birth. We have a cardio obstetrics clinic for which that we are seeing these high-risk women. Next slide. If you look at the data even further, what is shocking is to realize that when we look at ethnic and racial disparities, that our African-American Black women have the highest risk of cardiovascular mortality after pregnancy. In fact, Black women in the United States are 4 times more likely to die in pregnancy than their non-Black counterparts. In addition, Black women in the United States are 7 times more likely to die from cardiovascular disease in pregnancy, and a large portion of that is due to heart failure. So cardiovascular disease in women does span their entire life, from during pregnancy, post-pregnancy, and looking at long-term outcomes. Next slide. So I think the question at hand really is, should women receive the specific treatments when they need them, rather than asking, do women receive fewer treatments than men? I would hope in the next coming years that I can give this lecture and state that women don't have an increased mortality after a heart attack, that women do get all the treatments that they should at the time that they should. But really looking at enrolling women in clinical trials, particularly in cardiovascular prevention and treatment, is very important for half our population. This is something that I've become very passionate about, love speaking on, and I think being an advocate specifically for women who are pregnant and cardiovascular disease is one of the most important things that we can do here at the University of Arizona. I will end this lecture by telling you that there's a lot of simple things you can do as far as prevention. I think Dr. Nuno was gave a great example of what he personally did to change his pattern of behavior, but also that his family and friends supported him and his community. I will tell you, in clinical trials, women who are engaged in a community, whether it be a church community, a local community, a friend group that hold each other accountable, have better outcomes cardiovascularly than when they do it alone. So in this statement, I will tell you, ladies, that it does take a village. We need to work together and find communities, speak up for ourselves, and recognize that we have to be advocates on our own behalf. So I'd like to thank you for this opportunity, and I look forward to your questions. Thank you.
Thank you, Dr. Juneman. Next, we'll be handing it off to Ms. Melissa Lopez Pentecost. She is a registered dietitian and doctoral candidate in the College of Medicine. Ms. Lopez has received 2 NIH grants with a more recent F31 grant to investigate the role of diet and other lifestyle and psychological risk factors in modifying obesity-related chronic disease risk. Ms. Lopez has a passion to apply her knowledge and experience to improve health in underserved communities. Thank you, Ms. Lopez.
Thank you for the introduction, Sadiq. I just wanted to start this presentation by summarizing some key statistics, although some of this were already presented and we heard from Dr. Nuno and Dr. Juneman. But just to reiterate, cardiovascular disease is not only a US problem, but it is a global issue. And in the year of 2019, cardiovascular disease was accounted for 18.6 million deaths. Now, we also learned today that health disparities exist and that primarily minority populations such as Black individuals are at high risk and are affected by cardiovascular disease. Next. So there are many risk factors for heart disease. Some of them include non-modifiable, meaning we do not have control over them. That includes our race and ethnicity, our age, but there are also modifiable risk factors, which are those that we have control over. Now, the American Heart Association tracks key health factors that impact your risk for heart disease, and this includes smoking, blood sugar, blood pressure, cholesterol, physical activity, body weight, and a healthy diet. Now, eating a healthy diet reduces the majority of these controllable risk factors. So consuming a healthy diet helps maintain a normal blood glucose level. It helps maintain healthy cholesterol levels. Specifically, we're talking about lower LDL, which is considered the bad cholesterol, and higher HDL, which is considered the good cholesterol. Consuming a healthy diet helps us maintain normal blood pressure and maintain a healthy weight. Next. So we have some strategies that can help you adopt a healthier diet and overall not only prevent heart disease, but help you manage heart disease if you already have a diagnosis. So first recommendation is to increase your intake of fruits and vegetables. And I know we hear this all the time and it is sort of a cliche, but it is extremely important, and an easy and cheap way to do this is to follow seasonal items for many reasons. One of them is because they are much more cheap and affordable, but also it helps us get creative and choose different types of fruits and vegetables that otherwise we wouldn't, because we tend to follow patterns, we tend to follow our own habits and our own recipes. So choosing those seasonal fruits and vegetables is a way to step out of our comfort zone and consume different nutrients in those fruits and vegetables. So next we have consuming whole grains and increasing fiber consumption. So we can do this by choosing whole grain pastas, breads, choosing oatmeal for breakfast. And also, if you notice, by increasing our fruit and vegetable intake, as we just talked about, we're also increasing our fiber intake. So it is a 2 birds, 1 stone kind of situation with this one. Now we have consuming oily fish like salmon, which helps reduce inflammation due to its omega-3 content, and it is highly recommended from prevention and dietary treatment of heart disease. We also have lean meats and also low-fat dairy. So a big focus in preventing and treating heart disease is to reduce fat intake, with specifically reducing saturated fat intake. So by opting to choose leaner meats and low-fat dairy products, we are following this recommendation. We also have a focus on reducing sugar intake since they provide unnecessary calories, and this provide absolutely no nutritional value to our bodies. We have reducing salt intake, but more specifically, reducing sodium intake. Now, the majority of sodium in our diets doesn't come from table salt. It comes from processed foods such as ready-to-eat frozen meals. So paying attention to the amount of processed foods versus fresh foods or foods made from scratch is another way to reduce your sodium intake. And lastly, we have alcohol in moderation, if anything at all. Now, moving to the right side of the PowerPoint slide, a good strategy for healthy eating is focusing on eating the proper amount of the right foods. And following the recommendations of my plate, it's a very good starting place. So these recommendations include how to serve your meals on your plate. So we can see that half of your plate is recommended to be composed of fruits and vegetables, with a focus on more vegetables than fruits. A quarter of your plate should contain whole grains, and a quarter of your plate should be composed of lean proteins or plant proteins, preferably, again, because we are keeping an eye on those saturated fats. So we also have the dairy component, and this does not necessarily just mean drinking a glass of milk with your pasta, but it can also be some type of low-fat cheese or low-fat sour cream, etc. Now on the right, we can also have a real-life example of actual foods on how to build your plate. So this is just for you to get an idea. Next. Now, there are very specific guidelines provided by the American Heart Association, and I know we talked about some of this, but for example, for sodium intake, more specifically, the recommendation calls for consuming less than 2,300 milligrams per day. If you already have a diagnosis of high blood pressure or cardiovascular disease, the recommendation is to consume 1,500 milligrams per day. For saturated fats, the recommendation is to consume less than 10% of total calories. Although for a diagnosis or for presenting risk factors for cardiovascular disease, it's recommended to consume approximately 5 to 6% of total calories. For sugar, the recommendation calls for 100 calories per day for women and 115 calories per day for men. And lastly, for cholesterol, the recommendation is less than 300 if there's no diagnosis, or 200 milligrams if you are presenting with heart disease risk factors. Next. So another strategy to help you follow the specific recommendations is to look at the nutrition labels. Now, my biggest recommendation is to do this at the grocery store when you are trying to pick an item, pick which kind of canned product, etc. I wish I had more time to walk you through the specific components of a nutrition label, but we can see that on the nutritional label, you can find information that involves the recommendations that we just talked about. So we have saturated fats, cholesterol, sodium, and added sugars. But importantly, I want to remind you that when we are looking at the nutrition label, it is really important to look at the serving size. So if you're picking between two different products, make sure you're comparing apples to apples. So comparing the serving size that is the same as the other product. So in this case, we have 2/3 of a cup. So make sure you're comparing this item to another 2/3 of a cup, or we would have to do a little bit of conversion to see which one is the best option. Next. So overweight and obesity is a major controllable risk factor for heart disease. If you're starting to consider to lose weight, or you've already started your weight loss journey, I want to tell you that losing 5% of your current weight will have a significant positive impact on your health. So regardless if that is the weight that you are aiming at or that you're trying to be at or not, losing 5%, which is approximately 10 pounds or 4.5 kilograms, will reduce your risk for heart disease and many other preventable diseases like diabetes. Now, on the right, we have a summary of the strategies we discussed today, but I do want to highlight a couple of things that I haven't mentioned so far, and that includes when choosing canned fruits or vegetables, we have the options to choose and opt for light syrups, sugar-free, or low-sodium options. So even if you end up not choosing the low-sodium option, for example, a good way to reduce the sodium content of that product, let's just say corn, it is good to rinse the product out, and that'll get rid a little bit of the sodium content. Now, another thing is when cooking, choosing liquid vegetables instead of solid fats, it's a good strategy, and it makes a difference in reducing saturated fat intake. But even more so is the cooking method. So grilling, baking, broiling are the healthiest cooking method options. And then lastly, if you're starting a healthy lifestyle journey, I want to tell you that small changes make a big difference. You don't have to start with all of these tips. You don't have to start to try doing it all. You can start by choosing one and focusing on that one goal. And once you feel you have a habit, that you formed a habit and that you have that goal or that habit down, you can move on to the next ones. There are many diets and fat trends that work for the immediate outcome or for the immediate compensation of losing weight. But remember that when it comes to lifestyle habits, we want this to be on the long term. So focus on building those habits that you're going to be able to keep up for the rest of your life. And that's what's going to make a difference in your health. So thank you for your attention. If you have any questions, I will address those at the end of this presentation.
Thank you, Ms. Lopez. Next, we're going to be handing it back to Dr. Nuno to just tell us a little bit about the All of Us research program. There are some QR codes scattered throughout the slides so that you can check out the website as well as you go through the presentation. Thanks, Dr. Nuno.
Thank you, Sadiq. Hello all, it's my pleasure to be back to you to close out our round of speakers. And I'd just like to give a hand to all the speakers, Dr. Grander, Dr. Juneman, Ms. Lopez Pentecost, excellent information. I think really complimentary to what we all talked about the different factors, but great information all around. Next slide, please. So what it is my pleasure to talk about what exactly is the All of Us research program. So you can see my background here being 1 in a million. So we have some backgrounds that are really nice. And I guess I'll start with the quote from the NIH National Institutes of Health Director, Dr. Francis Collins. So quote, "All of Us is among the most ambitious research efforts that our nation has undertaken." So I think that just perfectly describes it. So it's a historic longitudinal effort created in 2015. And the goal is to gather data from 1 million or more people living in the United States to accelerate research and improve health. And it takes into account individual differences in lifestyle, socioeconomic, environment, and biology. So that with the hope that researchers can uncover paths toward delivering precision medicine or individualized prevention, treatment, and care for all of us. So hence the name. It's part of a broader precision medicine initiative, but as it currently stands, the most recent numbers showed that core participants that have completed all the surveys and donated their biospecimen data were about nationwide, just right under 300,000 participants nationwide. So on a good way in those 5 years, almost 6 years to reaching that 1 million goal. So it's been a great effort. Startup took a little time. And then we've had the COVID issues this past year and a half, but I think it shows excellent effort to recruit that many numbers to have a program to get that much data. And we'll see why that much data is important. Arizona specifically, we're about 45,000 core participants, which is actually #1 in the United States among states. So just a little, I guess, some bragging on our state part. I myself, I'm in my role in the All of Us program is as the co-lead of the engagement core. So it's the engagement core that does activities, announcements, tables at events at the hospital. So it's myself and Dr. Francisco Moreno are our co-leads of that part of the All of Us research program in Arizona. Next slide, please. So what is precision medicine? So precision medicine, it's an emerging approach for disease treatment and prevention that takes into account, as I mentioned earlier, those individual variability and lifestyle, socioeconomic, environment, and biology. So it's a radical shift how each of us can receive the best care possible based on our unique makeup. So the way medicine has been done, or treatment, prevention, so it's a one-size-fits-all approach. It's looking at the average and adjusting that medication treatment to the average. Well, as I tell I've taught an introduction to biostatistics to undergraduates here at the university, and we know that when we do measures, let's say we're doing a average or the measure for cholesterol level in milligrams per deciliter, we take a whole sample of how many number of people, and we take an average, and then among that average, then we have the standard deviation of variation. Well, that average is a calculated number. That's what that middle part of what everybody is. So it's the variation. It's the actual people. That's the real data. That's what exists. It's the average is the so to speak made up number, the middle part. So the one size fits all approach is what's been done. And what this precision medicine initiative is looking at the individual person and saying, okay, what is it about the person that their individual variability in lifestyle and socioeconomics, environment, and biology that'll help us to individualize the treatment or medication prevention strategy for them. And that's very exciting to be moving that forward. Next slide, please. So the types of questions that all of us may help answer. So how may we prevent the chronic pain that affects more than 100 million people across the United States each year? How may we develop pain medication that potentially may not be addictive? How may we develop better treatments for diabetes, which affect almost 10% of Americans, or may potentially prevent diabetes altogether? How may we slow or potentially stop different kinds of dementia? How may we help researchers develop more cancer cures that will work the first time, so we may skip the painful trial and error chemotherapy? And how we may drive sustainable interventions that may support health equity. So all of these are very important research questions that the All of Us research program is contributing to hopefully potentially help answer in the coming years. Next slide, please. So among the innovative aspects of All of Us, so diversity at the scale of 1 million or more people. So the goal is to recruit 1 million people. That's demographically, geographically, medically, and especially those underrepresented in biomedical research. At its current standing, I believe what that group called underrepresented in biomedical research, which can include racial, ethnic groups, male or females, rural populations, different types of geographic or racial, ethnic identities. I believe the numbers show about 80% of the 300,000 are UBR, underrepresented biomedical research, and among that 300,000, also looks like about 50% are different racial ethnic groups. So it's really on its way to reaching that diversity in the data collected for all of us to be able to answer those questions of diversity. So there's also diversity of data types collected longitudinally. So there's clinical, environmental, genetic, behavioral, and socioeconomic data. So focus on participants as partners. This is key. So they're included in the governance, invited to co-invent systems and give input into the science, and the choice to receive data and information back. So you have the choice to receive the data that's collected at baseline, the clinical, your blood lipid profile data, but also to get the DNA data back after it's evaluated, and you can request the results. I myself, along with being a co-lead and researcher, about a couple of years ago, I'm also a participant. So I signed up for the study. I had filled out the surveys, had my blood drawn, and I've gotten the email, the letter saying I can collect my DNA data. I haven't done it yet, so I'm a little behind on that. But I think it's very interesting to see what's in that information. And then it's a national open source for all. So it's open to public and all researchers, open source software and tools. So there's a program called All of Us Workbench, where researchers from around the country can participate, become investigators, and do research using this data to study all manners of health conditions. And you can see that we have a overlap of people, health status, data types, and geography. And sharing knowledge and data is the key. Next slide, please. And so this key part about participants. So what's the promise to participants? So overall, and we say this in a lot of studies, but especially true in this one, it's an opportunity to improve the health of future generations, to contribute to cures and potential cures in the future, to make a difference in the future. A chance to learn about your own health. So looking at your own triglyceride level, cholesterol level, getting your DNA results and seeing what predispositions you have. I went to a seminar, and one of the predispositions they talk about, a funny one, is you could be predisposed to the taste of cilantro. So that's something maybe kind of cool to know, but you can learn much more information too. But that was just one fun example they gave. The ability and choice to access your own data, including increasingly rich health records. The opportunity to ensure that your community is included in studies that lead to new understandings of what affects people's health. So, and a chance to learn about additional research opportunities that may interest you. So you can learn a lot of information about research, biomedical research, and the choice to meet others like you, perhaps even joining some of them to propose and do research. So it's a long-term relationship, and the value of participants in research will continue to grow over time. We're 5 years, 6 years into this, and it's the goal is to continue going on for at least the next few 5, 10 years, 20 years. So that's the goal, to move this cohort forward and these 1 million participants and be able to utilize that data for this precision medicine approach. Next slide, please. So the potential steps in the All of Us participant process. So as mentioned, you collect all this data. So it is a little involved in how you become involved in the study. So you have to enroll and consent and authorize electronic health records. So it's recruiting adults right now, 18 and older. Eventually do want to schedule children, but that's not being done right now. So you include authorization to share electronic health data. You consent to get DNA results, and it's a little involved consent form to participate in the study. So, and then you answer surveys. So you have surveys that you complete the initial survey. So there's basics, overall health, lifestyle, healthcare access, utilization, family medical history, personal health history. So all done on questionnaires, surveys. And then there's additional surveys will be released on an ongoing basis. So some things that come up as a COVID survey, how COVID has affected your health. And there's a social determinants of health survey that's in the works and should be released soon. So in addition to doing the surveys, you also give physical measurements. So your blood pressure, heart rate, height, weight, BMI is calculated, hip circumference, waist circumference. So that data is collected. And you provide your bio samples. So your blood is drawn, or saliva if blood draw is unsuccessful. And urine specimen and the biosamples are stored at the program's biobank. And then there's also the opportunity to wear wearables and digital apps. So it shares data from wearable fitness devices, starting with Fitbit, and more integrations are under development for these wearable and digital apps, which can give also more of that individual unique information from each person. So projects that are underway, they include richer electronic health record data, the health apps, the fitness wearables, and then again, the return of genetic info, which I myself, I'm curious, and I'm being part of this webinar kind of reminds me that I need to do that. So that's good for me to be here. Next slide, please. And I think that's a kind of an overview, the 10,000 height view of the All of Us program. Very involved, lots of people, there's large staff, large, hardworking, dedicated staff involved here in Arizona nationwide. We have team meetings in Arizona, and just in University of Arizona, we also have statewide meetings, national meetings. So as you can imagine, efforts such as to recruit 1 million participants is very involved, and there's lots of dedicated researchers and staff and faculty involved. So it's my pleasure to be here, and happy to move on to the Q&A session.
Thank you, Dr. Nuno. And thank you all of the panelists. We're so excited to have you, and it was so informative to hear each of you speak. So we're going to move into the Q&A session next. And so if you have any questions for the panelists, feel free to send them in the chat or post on social media. We've already had a few very interesting questions come through. So I'll go ahead and get started with them. The first question is for you, Dr. Grandner. And it revolves around seeking advice for individuals that work night shifts very regularly, and how that disrupts their sleep schedule. And this individual is saying that they do a great job with their diet, making sure that they're working out, doing all of the things, but when they switch from night shift work to regular shift work, or when they're trying to sleep, it's been difficult. And do you have any advice for that?
Yeah, I mean, there's good news and bad news. The bad news is that shift work is bad for you. I mean, we've have decades of data on this. The question in the sleep and circadian field seriously isn't, how is shift work a bad thing? Is it worse than smoking or not? It really is potentially that harmful. People who regularly work shifts, especially if they're not able to acclimate to those shifts because they move them, pretty much any adverse risk factor you look for, it's not the same in terms of the same effects as smoking in terms of lungs, but you get more diabetes, more weight gain, especially a lot of cancers, because the clocks at the molecular level in every tissue in the body get disrupted when you get this disrupting environment. So I guess the first thing I'm saying is, yeah, shift work, it's sort of like saying, well, I smoke a pack a day. What can I do to help prevent heart disease? Like, well, there's still lots of things you can do. So and it's just because we live in a society that requires shift work. We haven't found a solution for this yet. So how do we work within the system? The first and most important thing I can tell you based on the data is the more regular you can keep your schedule, or at least can you keep your sleep-wake windows, the more consistent you can keep them, the better it's going to be, even if it means for a while, even on off days, you might be awake at times that are inconvenient. If you can keep your schedule more consistent, that's going to be better. But other things you can do, take naps. You don't need to get all of your sleep in one bout. You can get a few hours at a time. Short naps are good for people who are otherwise well rested, can boost performance, but people who are trying to make up sleep, you can take a longer nap of 2 to 4 hours, sort of like a sleep replacement nap, like a meal replacement bar. You wouldn't confuse it for a full meal, but it sometimes gets the job done. And when you're sleeping during the day or sleeping at a time your body doesn't necessarily want to sleep, that sleep may be more shallow, so you need to protect it. That means, eye masks and earplugs and all of these other environmental things. So other things you can do. The best advice I have in terms of helping to get you to have the ability to be in control of sleeping, especially at a time when your body may or may not want to, is actually, if you are super reliable about having a place that you sleep, like your bed, and when you're in that bed, you sleep. And if you're in that bed and you're not able to sleep, you get up for a little bit and try again. Eventually, you can train yourself to sleep in bed. You want the bed to be like you go to the gym. Even if you're tired, you can make it through your whole workout because that's all you do there. If you walk in your favorite restaurant, even if you're not super hungry, you get hungry because that's what you do there. It's tied to that mental and physical state is tied to that place. You want to create that for the bed, so that even if it's an off time, or even if you're not super tired, or even for whatever reason, the bed itself can be a signal for sleep. You can train yourself to do that. It's actually a very powerful approach. So unfortunately, we live in a society where a lot of people have to work shifts, and human body does not like that. We're the only species that does this on purpose to ourselves. But there are some ways to potentially mitigate some of that.
Thank you, Dr. Grandner. So the next question is for Dr. Juneman. And a couple of questions, they're related, and they revolve around pregnant women and predisposition to developing peri and postpartum cardiomyopathy. Is there data suggesting increased risk of coronary artery disease and ischemic cardiomyopathy, diastolic congestive heart failure, and what factors should we screen and attempt to control in pregnant females to prevent this heart disease? I think you're muted, Dr. Juneman.
Thank you. I was following the rules and muting when I wasn't speaking. That's a really good question. So I think there's a couple of factors at play here. I think the number one is that if you ask women, do they think that cardiovascular disease is a risk, a majority of women will, regardless of the age, will say, not me. So I think number one is awareness that women at any age have a risk for cardiovascular disease. I think when you look at younger women, I think younger women do not understand or appreciate that cardiovascular disease, particularly hypertension, diabetes, and stroke, really are risk factors for younger women. So I think it's partially information, and that's why we see the American Heart Association specifically with the red dress, or in my case, a red coat, campaign to try and bring awareness. So number one, I think it's awareness. Number two, I think that a lot of the underlying disease states that we see that's causing this increase in cardiovascular mortality are related to preventable diseases. So let's take the epidemic of obesity in the United States. Along that comes with diabetes, high blood pressure, maybe a metabolic syndrome. And so while information and education is the primary issue, I think number two, it's what we see as far as a lack of prevention for cardiovascular disease at a very young age. When we look specifically at pregnant women, when I see a pregnant woman and let's say do pre-pregnancy counseling, a couple of things that I always come to mind. Number one is what's their underlying exercise capacity? Are they exercising on a daily basis? Do they eat a diet that is, high in fiber, following a Mediterranean? Do they have a lower sugar intake? Do they watch their salt intake? So I think that's where diet becomes really important in a pre-pregnancy counseling. Likewise, I encourage all women, regardless of the ages, to know their blood pressure. Be aware, right? Don't avoid going to the doctor because you're going to get your blood pressure. Most women don't like to go to the doctor because they're afraid to get on a scale. Your scale is a friend. Your scale helps you. It's a biometric that helps you track your overall disease. So those are two things. So we talk about blood pressure, we talk about weight, we talk about exercise capacity. And then there is some thought that family history plays a part. So I will ask my pregnant or pre-pregnant ladies, what was your mother's pregnancies like? Have you had any miscarriages? What did your sister have preeclampsia? And kind of addressing gestational diabetes or high blood pressure in pregnancy can help guide me about what their risk factors are. I'm very straightforward also about understanding that particularly with my African-American and Black patients, and being very open with them that their risk is higher for post-pregnancy disease. And I tell them they have to speak up. They should not be okay with being dismissed. They have to be vocal, they have to seek care, and they have to be very proactive and do not be dismissed. So when we look at the risk factors for cardiovascular disease in pregnancy are the same risk factors that we see in development of cardiovascular disease in the long term. I think that education is a really important part of that, as well as prevention.
Thank you, Dr. Juneman. And to follow up with that, do you have any recommendations when a woman is pregnant on what they should ask their doctor with regards to heart disease?
Yeah, absolutely. I would recommend, number one, there's going to be a website that can be given to you. It's from the American College of Cardiology. It's called Cardio Smart. And there's a women and heart disease section. And there's actually an entire section on women and pregnancy. And within that, there are signs and symptoms that pregnant women can be aware of, such as, worsening shortness of breath that is out of proportion to a normal pregnancy, high blood pressure, making sure that they actually measure their blood pressure, have a blood pressure, just like we should have a scale and a thermometer at home. We should also have a blood pressure cuff. I also talk to women a little bit about not dismissing their symptoms. I'm a big advocate at making sure that these women get really good sleep. So going to Dr. Grandner, I understand that pregnancy can be uncomfortable, but making sure that they are getting their exercise, getting good sleep, and really having an open conversation with their obstetrician about the symptoms they're having. Not every pregnant woman needs to see a cardiologist, but if there are signs and symptoms that are suggestive, then there are cardiologists that do specialize in treating these women.
Thank you. The next question is for Ms. Lopez. So this is a little technical, but you suggested that reducing sodium is important for heart health. How would you address the problem with people when they're dealing with chronic illnesses where increased sodium intake is one of the treatments? So things like POTS or Ehlers-Danlos syndrome. And maybe Dr. Juneman, you both can tag team this a little bit.
Yeah, so I think the first thing is to remember that there are many dietary habits that you can adopt. So not only the sodium thing, high sodium intake can put you at risk or worsen your diagnosis. It's the combination. So where is your whole lifestyle? Where are your dietary habits at? So although you may have some or not control over your sodium intake based on your other medical diagnosis, where is your saturated fat intake? Are you taking care of your high fiber? Are you addressing these other recommendations that overall are going to help you to reduce your risk? Sometimes we forget that foods are consumed in combination, not in isolation. So it's not just one thing that's going to make you sick or result in disease. Is your whole lifestyle, is your whole dietary pattern, is your whole all of your dietary habits, your physical activity. We didn't talk about physical activity specifically too, but where is that in your whole lifestyle picture? So that's what I would recommend, is focus on the items or the areas that you have more control over, because overall they do make a difference when you're addressing these other areas in your lifestyle.
Thank you. Dr. Juneman, did you want to add anything to that? I think Ms. Lopez did a great job.
No, I completely would agree with everything that she said. There are specific situations, and I think you alluded to one of them. It's called POTS. It's postural orthostatic tachycardic syndrome. This is a dysfunction of a part of the nervous system that causes women more likely than men to have abnormal reactions to changing in position, let's say sitting or lying to sitting to standing. In those specific cases, we do encourage salt intake, but that's a very rare kind of a small population for which that we don't advocate salt restriction. But in most cases, and I'm saying 99.9% of the cases of cardiovascular disease, we actually really do like people to monitor their salt intake. And I would 100% agree that it's not just one meal that dictates whether you win or lose based on your choices, but it is a summation of your time, right? If you have a bad day and you don't get good sleep and you make bad food choices for that day, and maybe you eat packaged food, don't beat yourself up about it. There's always tomorrow, and it's a culmination of your choices over a long period of time. Too often I see people, give up just because they have a couple of days or maybe a week for which that wasn't good. And we are humans. It takes, 1 week to lose a habit. It takes 4 weeks to develop a good habit. And so I encourage everybody to just keep on and looking at that long-term goal.
Thank you, Dr. Juneman. So the next question is for Dr. Nuno. What can folks do to combat health disparities, and what can be done on an individual level?
So I think on the individual level, what we're talking about here is trying to follow the advice, the diet and the exercise and the good behavioral habits, doing our best at the individual level to follow those. Trying to find out what works best for us. Is it maybe the difference between low carb and low fat, seeing what works best for you, but in general, trying to follow that advice that Ms. Lopez Pentecost mentioned, the fruits and vegetables, good fiber, lean meats. Those are all things to strive for. And I think this previous discussion right now about don't beat yourself up. Yeah, we're going to have days where we eat bad. The key is not to make that a habit of every day. We have birthdays, we have celebrations, we have birthday cake. The key is not to start eating that every day and where it becomes your daily habit. So on the individual factors, things you can do to try to modify your behavior. I also think one of the things we haven't mentioned all here, but a big one is smoking. Hopefully nobody's a smoker here. That's probably the #1 thing we can give up. If anybody's a current smoker out there, that's probably the best thing you could do, is to stop smoking. I actually didn't bring it up because among Hispanics, that's actually one of the things the Hispanic population is better on, the low smoking prevalence there overall. And I think that's one big factor. And I'm a big believer in the individual is where it starts, but it also continues if you have the support of family, friends, community. That makes a big difference. If you have the contacts, the friends you can make, the people that support you. And if you're lucky enough to have the systems, the usual primary care provider, a healthcare system, the health insurance, those are all great. That'll help benefit. And as I mentioned, those stories about if you don't have that, but those stories about I guess it's the exception, is the person that can overcome all the obstacles they have. Boy, we admire them. That's awesome. And that's great to see that. And I wish everybody luck on that to overcome that. And I believe it's possible, but I'm definitely a firm believer that should be the exception. That shouldn't be the rule for everybody. Everybody should have the opportunity for good health.
And I will add just one thing. I mean, I'm a really big believer as far as community. In women in cardiovascular disease, we've seen time and time again that even whether it's based in a church, a synagogue, whether it's a neighborhood, whether it's families, getting together and talking about this. I mean, women don't ask other women what their heart health is, and we should. We should be looking out for our brothers and our uncles and our fathers as well. And so I think being able to talk about this in a community is really important, because we do all make mistakes. There are birthdays, and it's okay. We need to celebrate those things, but holding each other accountable and bringing community together is very important.
My father has a saying. He would tell us when we were growing up, I guess he learned this in his school growing up in Mexico, but it was a sound mind, sound body, and sound spirit, actually. So it's what you put into your body mentally, physically, and spiritually. I think those are important. And that's another, I meant smoking came to now, but spiritually too. I think that's a factor that's important to a lot of people. And if you have that, it doesn't matter. It doesn't mean, or it can mean a religion, or it can mean nature, it can mean whatever brings you that inner peace. Is important.
Thank you, Dr. Nuno and Dr. Juneman. So we have one more question. And this is specifically, so I'll just read the question. So the individual asked, women are said to be more resilient compared to our male counterparts, and probably have more tolerance to pain and other symptoms. Do you find this to be true? That women are, do you find this to be true? And is this why women are diagnosed later compared to men when dealing with diseases? You're muted.
I think there's a lot to mention in this aspect. I think, first of all, women can have typical cardiac symptoms, but women can also have very unusual symptoms, such that sometimes they themselves and maybe their providers or their family members don't recognize that they're actually true cardiac. I think, number two, women tend to put others before their own health. So classic is the busy, mother, that has to balance, a house, children, possibly pets, maybe a job, maybe elderly parents, and taking care of everyone, maybe putting their own care lower on the list. I think part of women presenting later may be gender specific, but I'm going to tell you that it's not just a change in estrogen and progesterone. I mean, I think we originally thought that women were, smaller men and we had more estrogen and less testosterone. And a lot of the animal models have shown that it is much more complex than just the fact that we have different levels of hormones and hormone shifts. There is probably some component of a perimenopausal or postmenopausal change in maybe metabolism and or how we process, let's say, food or cholesterol that may add to the fact that women are later diagnosed. But like most things in human health, it's multifactorial. So I think it is personal in regards to we put people first. I think from a family standpoint, maybe we don't talk about this with our loved ones and we fail to recognize our risk factors. From a society standpoint, I don't think it is just our hormones. I think there are other things that make us present with perhaps similar symptoms, but sometimes very unusual symptoms. And I think as far as a healthcare system, recognizing that, women do present differently and we have to look at that. I think I'm a scientist at heart and truly believe that with enrollment in women in clinical trials and with good education and public health, there's a lot of this that we can do gender and disease specific treatments. But it will take research and it will take enrollment and it will take education and it will take public health. So yes, I like to think women are more resilient, but I think that somewhat disparages our male colleagues. And I'd like to say that we are all individual. We all have our own story. And I think that there's a lot of things that allow women to be diagnosed perhaps later.
I think that's a perfect segue, Dr. Juneman, to what all of us can potentially promise is in terms of personalized or in medicine, and how being able to look at the different factors women and men face in their own individual lifestyle profile, clinical profile, behavioral, so economic, socioeconomic, and environmental factors.
Thank you so much, Dr. Juneman and Dr. Nuno. So that is everything that we had today. Thank you so much, panelists, Ms. Lopez Pentecost, Dr. Nuno, Dr. Juneman, and Dr. Grandner. We appreciate your time so much. And thank you to all of you for attending our session. As you exit this Zoom link or on Facebook, you will get a post-webinar survey. So we would really appreciate if you would fill that out, or you may receive it in your email just to get some feedback to see what you would like to see in the future. But we'll go ahead and wrap up there. Thank you so much.
Thank you.
Thank you, Sadiq. Thank you, everybody.